All right, we will now begin this PATH Collaborative Planning and Implementation Initiative Best Practices webinar, Improving CalAIM Engagement for Eligible Individuals. I'm going to turn it over to DHCS to get us started. Next slide.
Hi, everyone. So my name is Shell Wong, and I'm here with DHCS as the Chief over our Project Coordination section. I just want to say we are really excited to see all of the participants today, and it looks like that number is still going up, that are here looking to learn strategies to help support your engagement with CalAIM and the goal of improving the quality of life and health outcomes for our populations. Also joined with me from DHCS today, we have Michael Weezer, Chief over the Managed Care Program Oversight Branch, as well as Jasmine Garcia, our PATH Unit Chief. Joining from our third-party administrator public consulting group is Rebecca Rose, CPI Program Manager, and Emma Trucks, our CPI Senior Advisor. We're also excited today to have our speakers from BluePath Health and HCT Strategies. Once again, thank you everyone for joining, and looking forward to hearing more. I will pass it over to Emma.
Thank you, Shell. So I'm Emma Trucks, CPI Senior Advisor, and a few notes about today. First of all, I'll just note that today we will be dropping all available links to various resources that are discussed in the presentation into the chat. We'll kind of push those forward to you in that way. Additionally, the slides and a recording of today's event, along with a Q&A companion, will be posted on the CPI website within the next few weeks after the event. As you listen to today's presentation, we hope that you'll get a lot of ideas and start to generate questions for our presenters. And you can use the Q&A feature within Zoom to submit your questions to our presenters or to the CPI team. And we'll be able to field some questions live during the Q&A portion at the end of the event. And we'll type in responses to other questions and then respond to other relevant and common questions in that Q&A document to be posted after the event. We have a wonderful agenda for you today. We'll be starting off by going over a bit of an introduction to the PATH CPI program and this best practice webinar series for those that may be new to this. We'll then go into our first strategy. We'll be learning about ECM and community support job aids to assist frontline staff with referrals, among other benefits, and that will be with the BluePath Health team. We'll then talk about strategies related to building engagement through relationships, including a CalAIM coordinator role, case finding, and warm handoff practices from HC2 strategies. We'll move into the Q&A, and before you leave, we'll have launched a brief evaluation poll, which we hope you'll take a moment to complete. Next slide. And I'll turn it over to Rebecca to give a brief orientation to CPI.
Thank you, Emma, and good morning, everyone. We're so glad that you are here. So what is PATH? Providing Access and Transforming Health. PATH is a 5-year, $1.8 billion initiative to build up the capacity and infrastructure of on-the-ground partners, such as community-based organizations, hospitals, county agencies, designees of Indian health programs, and others, to successfully participate in the Medi-Cal delivery system as California widely implements enhanced care management and community supports justice involved services under the CalAIM initiative. The PATH funding is intended to complement and enhance other CalAIM efforts and is not and should not be serving as the primary source of funding. PATH funding for all initiatives is time limited and should not be viewed as sustainable or an ongoing source of funding. Next slide. There are 4 key PATH program initiatives: the capacity and infrastructure, transition, expansion, and development, or the cited initiative, the technical assistant marketplace initiative, the justice involved capacity building initiative, and the collaborative planning and implementation, or affectionately called CPI initiative, and is where we are in focusing our efforts today with the CPI initiative. Next slide. Just a background for the CPI initiative. The local CPI collaboratives work together to identify, discuss, and resolve topical implementation issues and identify how PATH and other CalAIM funding initiatives may be used to address gaps identified in the Medi-Cal managed care plan, needs assessment, and gap filling plans while avoiding duplications. There is a single PATH-funded CPI group in each region, and there are currently 26 collaboratives that operate across the state with 9 facilitating organizations, which join together stakeholders in their regions to convene and facilitate county, regional, and CPI efforts. The collaborative facilitators continue to work with participants to identify these best practices, develop resources, and test strategies that support entities engaging in ECM and community support efforts. The CPI funding is used to support the designated CPI facilitators in each region, and individual CPI recipients do not receive funding for this initiative. However, do not need to be a CPI registered participant to receive cited funds. Next slide. Since registration opened for the CPI initiative in August 2022 to April 2024, we have 1,160 individual organizations registered and participating in the CPI initiative. The organizations range from CBOs, MCPs, Department of Health, and designees of Indian health programs. All of the area of interests that are talked about and reviewed during the CPI collaborative meetings that are occurring on a monthly basis range from capacity development and training to populations of focus to health outcomes and IT workflows and systems. Next slide. As you can see here in this slide, the 1,160 registered organizations are represented across all counties across the state of California, from Alameda to Yuba County. There's great representation in each one of these counties as it currently is with the CPI collaboratives. And with that overview, I'm going to pass it back to Emma to discuss the best practice webinar series objectives and introduce our first speaker.
Thanks, Rebecca. Yeah, so with all of those organizations and all of those individuals participating in CPI across California, one of the main goals of this webinar series is really to highlight best practices for implementation of ECM and community supports that we're learning from that kind of collective effort across the state. We also aim to increase providers' successful participation in CalAIM and improve collaboration with MCPs, state and local government agencies, and others to build and deliver quality services for Medi-Cal members. And next slide, particularly today, our first topic that we're going to dig into is about the ECM and community supports job aids to support frontline staff. Next slide. After BluePath's presentation, we hope that you'll be able to identify how concise provider-facing materials can support CalAIM implementation by improving a provider's ability to explain services to those who are eligible, among other benefits that the BluePath team will discuss. As well, we hope you'll be looking to adapt these materials to create your own county-specific resource or access the ones that exist. Next slide. BluePath Health is a small women-owned health policy, strategy, and technology consulting firm located in the Bay Area. BluePath provides healthcare consulting to health systems, government and commercial payers, technology providers, and grant makers. The team develops forward-thinking policies and strategies that improve care delivery and community health. We have with us Stephanie Thornton and Madison Olmstead. Stephanie joined BluePath Health in 2022. She supports projects related to telehealth, Medi-Cal, and health information exchange. Stephanie works with BluePath's clients and coalitions to analyze healthcare policy and create presentations and educational materials that provide recommendations for implementation in California. She is well-versed in the budget and legislative processes and has worked extensively to support efforts to improve access in the Medi-Cal program. Madison joined BluePath Health as a manager in 2023. She provides project management, policy analysis, and strategic communication skills to support numerous complex initiatives, including the CalAIM Alameda PATH Collaborative. She comes to BluePath Health with experience working in health policy and public health within nonprofit, state government, and federal government settings. I'm going to turn it over to Stephanie and Madison. Next slide.
Thanks so much, Emma. Hi, everyone. It's so nice to be here with you all. I want to thank the PCG team and DHCS for having us on today's webinar. We're really excited to share a little bit about this resource that we've been working on in our collaboratives. As Emma mentioned, BluePath Health is lucky enough to facilitate both the Alameda County Collaborative and the Tri-Counties Collaborative, which spans San Luis Obispo, Santa Barbara, and Ventura counties. One of our primary goals as collaborative facilitators is to create easy-to-use tools that support ECM and community supports providers. So as we started this tool development process, we heard a few key themes from our CPI participants that informed the development of this job aid that we're going to talk about today. First, CalAIM is still new. Many community-based organizations are learning how to enroll members into these services and learning about the components of ECM and community supports. Many provider organizations are staffing up to start their ECM or community supports programs, hiring many new CalAIM team members each month. Second, we heard that many CalAIM terms are not well known in the community, and that medical jargon can get in the way of communicating the value of these services to members. So if we focus too much on complex definitions or rely too heavily on terms like enhanced care management or population of focus that might not be well known, we're not actually communicating well how these services can really improve people's lives. The nuances and eligibility criteria can be pretty difficult to explain. Third, we heard that there was sometimes confusion, especially for ECM programs launching, and both on the provider side and the member side, about how enhanced care management or community supports might fit into care plans or existing services that someone's already receiving. Many organizations have existing relationships with their community members, but they're bringing in ECM and community supports. And lastly, we heard that existing CalAIM resources did not always meet the on-the-job needs of provider organizations. Some resources are long policy documents that are really helpful for studying or digesting when you have, an hour or two of desk time, but are not super accessible when a member is standing right in front of you and needs help. And some other CalAIM resources were short summaries that were super easy to understand, but didn't have as much actionable information related to the county that each organization was working on that providers really wished for. So our goal was, of course, to work together as collaboratives to try and fill this gap. So with our stakeholders, we started designing a resource that helps providers and frontline staff explain what enhanced care management or ECM and what community supports are and who's eligible. So we started this process in 2023. We've been working at this for quite a while to really get it to the place where it's the most helpful for the most number of organizations. We've engaged with the providers and the numerous stakeholders who attend both of our collaboratives to continuously gather feedback and make changes to this resource. The latest version of this resource, which you'll all be receiving as part of the post-webinar materials, was just launched this month in June 2024. So for over a year, we've created, I think...
Jump in. Can we go to the next slide so that everyone can follow along? Thanks.
So we've been working at developing this over the past year. Great. So our team at BluePath Health created an initial version of this resource that explained ECM and community support services, and we tested it with providers in multiple counties. During this initial phase of testing, participants shared that it would be really helpful to have this resource in Spanish as well. So we translated it, and that became version 2, along with a few other recommended changes from our local stakeholders. In stage 2, this job aid was tested by over 30 providers. And at this point, a few participants also shared with us that what would be really helpful was an additional page summarizing the 9 enhanced care management populations of focus. So we went about moving into our next phase of updating this document to add that second page that really breaks down those 9 ECM populations of focus all in one place. And that's now used across our 4 counties that we work in as PATH facilitators. Next slide, please. Great. So the resources we created that are shown on the slide right now are county specific. Since managed care plans elect which community supports to offer, we heard very loud and clear from providers that it's important to have documents available to them and to their teams that only reflect what's actually available in their county. So this example on the screen right now is from San Luis Obispo and Santa Barbara counties. The community supports descriptions that you see here contain plain language describing each available community support in the county and practical information about what the services entail. For ECM, this page includes the short talking points, the bullets, the really, high-level, fast and furious info that providers have indicated to us is the most important information they need at hand when describing what ECM is to an individual they're working with. And again, this resource is available in both English and Spanish. So if we go to the next slide, you can take a look at this side too. As I just mentioned, this was part of our more recent iteration of this tool. And designed really to provide succinct information on the ECM populations of focus. Condensing all of the ECM population of focus information into one page was difficult. I'm sure many of you who've read the policy guidance numerous times likely know that. But we have found that having it all in one place really makes this as usable as possible. Because ECM is standardized across all counties, this side too can be used wherever you're located. We encourage all of you to check it out, use it however it might benefit your work. And with that, I think we can go to the next slide, and I'm going to pass it over to my colleague Madison to talk a little bit more about our development and testing process.
Thank you, Stephanie. So as we have tested and iterated on this tool with providers in the field, we've learned that it serves more purposes beyond just helping providers explain ECM and community supports to members. So those other purposes include serving as an easy tool to incorporate into new hire training. It offers an introduction to CalAIM for providers who are new to the program, which is most given the recent launch of these services. It acts as a reliable, quick reference document, just one page front and back, that providers can easily come back to as often as they need for a refresher on this information. Some have even laminated it and have it at their desk or station. It allows providers to explain terminology that is new to clients and have that explanatory language at their fingertips. The fact that it's available in Spanish helps support consistent translation, and it can ease the burden on bilingual providers to be translating these terms and definitions on the spot. And then it can also be made available electronically, for example, through a QR code for easy provider access in the field, even when they do not have a physical copy in front of them. Next slide, please. We have received feedback from numerous providers describing the impact of the job aid on their work. Good Samaritan Shelter, an ECM and community supports provider in Santa Barbara, has implemented the use of the job aid across their organization. Part of this quote from a Good Samaritan team member reads, "Simply having access to basic information about CalAIM programs has increased the confidence of our staff in explaining these benefits to clients and increases the likelihood that clients will actually take advantage of these incredible services." So Good Samaritan is seeing that by being able to succinctly and easily explain these services, it actually helps get people willing to enroll in the programs. Next slide, please. The job aid has also been supportive to providers who are not yet offering ECM or community supports, but want to share about the services to help their clients and fellow providers. A collaborative participant from Glen Park Senior Living in the Tri-Counties, which is a non-contracted organization, has used the job aid when connecting with other providers serving their population to spread awareness of ECM and community supports. He shared, in the assisted living field, I've been handing out the community supports list to everyone I speak with because getting the word out about all the available supports is very important. I met so many people that can benefit from many of the options. I feel it's important to let the community know what is available. So the job aid has been, we've been seeing it really spread information broadly across the community and raise awareness of CalAIM services. Next slide, please. So throughout the process of building and launching this resource, we've really learned the value of county-specific resources that are designed with ease of use for providers in mind. Our lessons from the field include that providers needed a tool to ease the process of explaining services to members. Providers seek county-specific resources that reflect the actual services that are available to their clients and members rather than what is available generally statewide. Plain language resources can meet the needs of multiple provider and staff roles and audiences. So from frontline lead care managers and community health workers, as well as program managers, have all found plain language explanations of the services to be helpful in their roles. Offering a translated provider-facing tool ensures the services are communicated consistently. And we also heard that electronic access, such as a QR code to the resource, is something that has been requested as a way to make the resource more accessible in the field. So we really hope that this information has gotten the wheels turning for you all on how to share county-specific CalAIM information in your communities. Stephanie and I and our team at BluePath Health are happy to connect with anyone who's interested in adapting the resource. And I think was already mentioned, the links are there in the chat for you to take a look at the ones we have available, and they will also be sent out after the webinar. So we look forward to your questions in the Q&A, and thank you so much.
Thank you so much, Stephanie and Madison. Yes, we hope you all engage with those links, those resources, and consider using them yourself. Next, we're going to talk about building engagement through relationships, specifically the CalAIM coordinator role, case finding, and warm handoffs. Next slide. At the end of HC2's presentation, we hope that you'll identify new opportunities to establish connective activities between CBOs, healthcare, and government to improve care coordination, that you can apply strategies for case finding to drive new referrals, and that you can adapt a warm handoff tool to your local context. Next slide. All right, so just to introduce our presenters and their organizations, we'll start off with HC2 Strategies, which is a California-based company and facilitates 8 of the CalAIM PATH collaboratives covering 24 counties and the Indian Health Statewide Collaborative in partnership with the Institute for Healthcare Improvement. HC2, which stands for Healthy Connected Communities, aims to integrate the clinical and social aspects of community health to improve equity and reduce health disparities. First, we have Lauren Harden, the Chief Integration Officer at HC2 Strategies. She's a nationally recognized leader in building connected communities of care for complex and underserved populations. She was part of the team who developed Camden Coalition's National Center for Complex Health and Social Needs, serving as their senior advisor, partnering with communities in more than 30 states to develop connected communities of care. Lauren's past work includes developing an award-winning complex care model that creates better patient navigation, decreased hospitalizations, and costs for vulnerable populations. We're also happy to have Eddie Turner here today. Eddie is a Senior Director for Population Health and Equity for the Institute for Healthcare Improvement. The IHI has used improvement science to advance and sustain better outcomes in health and healthcare all around the world. Eddie leads IHI's healthcare transformation work in California. Previously at Community Solutions, he led coaching and improvement programs that empowered 14 US cities and counties to measurably end homelessness in key populations. And he is charged with accelerating learning in HC2's PATH collaboratives, specifically Inland Empire and Orange County. And from the Kings Tulare Homeless Alliance, we have Iris Gitcho in the relatively new role of CalAIM coordinator. The Kings Tulare Homeless Alliance is a consortium of partners that includes homeless service providers, advocacy groups, government agencies, and homeless individuals who work together to address the housing and support service needs of the homeless in Kings and Tulare counties in the San Joaquin Valley. IRIS supports CalAIM implementation in these counties by serving those who are serving Medi-Cal members and building a connected community of care among providers. Her background includes mental health, street outreach, and housing navigation, including in downtown LA. So there's a wealth of knowledge and experience in this next segment, and I'll turn it over to Lauren to get us started. Next slide, please.
Thank you so much, Emma. We really appreciate being here. We're really excited to share with you some of the things we've been learning in our work, and we want to acknowledge all the wonderful efforts, work, and innovation all of you have been doing in transforming people's lives, learning all of these new skills and refining delivery as we're implementing this groundbreaking innovation to meet the needs of our community members. So our first topic, we're going to focus on coordinating care. So we go to the next slide. Eddie, do you want to talk about this?
Thank you, Lauren. We're all here on this call because one of the main things that we have in common is we're thinking about how to serve clients better, how to meet their needs, and how to array these services so that the services meet all the needs that folks have. What we have learned is that as we think about coordination, when coordination activities happen really excellently, they not only meet client needs, they also serve the people who serve the people. When you do coordination really well, and CalAIM is a great occasion in which to think about how to do coordination really well, consistently we find that the jobs of frontline staff become easier and more effective. And so some of the common practices that we're seeing both nationally, but also across California, and in particular in Tulare County, which Iris will speak to in a couple of minutes, here are some of those practices. The first is a community facilitator and integrator. Now, maybe you are lucky like Tulare in Kings County, and you have someone like Iris, whose full-time job it is to think about how to bring folks together across agencies, across community support services and ECM, and integrate them for the benefit of the client. Maybe it's no one's full-time job, and so a little bit more creative problem solving will be required to think about how to integrate them, but no matter what, someone's got to figure out how to do it. So we'll think about that. Education and training for all those providers and people who could be making referrals. We know that the training is a process. It's never a one and done. It's never just one task that gets checked off and now you don't have to think about it again. It's a process. So we know that the education and training activities that allow people to apply their learning as they go are the most effective, and training that allows peers to teach each other the best practices and the things that work really well, we see as most effective. A thing that we say around Institute for Healthcare Improvement is change moves at the speed of trust. And that's why relationship building is the third practice on here. It's great to have a case conferencing meeting. All of us love case conferencing meetings, in part because they're opportunities to build relationships. As frontline staff gets to know one another, as people across agencies get to know one another, it gets a lot easier to do creative problem solving together to meet the client's needs. And again, make the case managers' jobs a little bit simpler and easier. I mentioned case conferencing. We think it's a vital practice. We think you've got to have a recurring meeting where people get together and collaborate on ways to support clients and meet those needs. We know that you also need to zoom out past your particular agency, past the particular client that you're working with today, and think about how to work at the system level. How do all of us together create a system across this county or across this region? The improvements that you can make thinking about that outside the silo of your agency are the hardest one, but also the most valuable. And finally, we think about providers and the whole community as the client when we think about being client-centered. So let's get into that. Lauren, tell us where you're doing some of this learning from on the next slide.
Definitely. So we've had the privilege of working in a lot of different parts of the country, and we wanted to share with you some national resources that you can dive into later. If you're a reader, if you like to hear from other communities, how did they do this? How did they come together and create a really integrated way of addressing the needs of community members? Here's some great practices. So accountable care communities, Pathways Community Hub, are some of them are in California. They're also across the country. There's stories there about hubs where community health workers are following pathways to meet needs in the community. With Medicaid 1115 waivers across the country, there are different roles emerging, like in North Carolina, where they have a network lead entity role, that sort of integrator, coordinator to bring people together. And then there's a really great resource that's emerged nationally over the last couple of years, the Partnership to Align Social Care. This collaborative of federal government, payers, providers, really people who have been thinking a lot about how do we help communities come together? What are the resources we need to understand and learn more about this and really sustainably finance that kind of approach? This organization has a tremendous amount of tools and resources you can read. But the really exciting thing is right here in California, we have a wonderful best practices happening with Kings and Tulare County with the CalAIM coordinator role. So I'm going to turn it over to Iris to talk a little bit about that in action right here in California.
Hello, everyone. So like Emma mentioned, my background is in direct service. I have a history of working with people experiencing homelessness on the street where they are. And in that role, I learned what's important to them, and their stories are basically the lens that I use to view this job through. So yeah, we have a great community. Kings and Tulare counties are rural, relatively rural. A lot of wonderful providers, dozens of providers. All working hard to serve the same folks, but we weren't all working together to serve those folks. So as CalAIM coordinator, the primary goal that I keep in my mind all daily is to help us all see each other as one unit working toward the same goal, which is basically to end homelessness in our area. But so yeah, so we meet, we meet regularly, and we are getting to know one another, and I'm kind of helping drive that a little bit, so that each member we serve has access to every resource that is possible for them to have access to.
Such an amazing resource, and I've heard you describe it as serving the people who serve the people. Having an integrator role, I think, is so key and really helps to move this work forward faster.
That's basically how I see it. Real quick, I'm sorry, I'll interrupt you. That
No,
yeah,
this is
no,
for
this is
dialogue.
that's how I see it. So what I've done is I basically have taken our homeless response system, and the intersection between our homeless response system and CalAIM, and made that my client. And so like the same, I work toward helping that intersection reach its potential. And so anyway, the same way that I would if I were working with a person experiencing homelessness, instead I'm working with the system.
That's a great parallel. Well, I'll tell you, Iris, it's been fun and honestly like a privilege to watch you figure out how to treat the constituent providers, sort of like clients. Give us a couple of examples. I said we all love case conferencing. Tell us about what your role in case conferencing looks like and how you help wrap CalAIM into the homelessness case conferencing.
Okay, so in our area, we were already doing pretty regular case conferencing through a bi-county case conferencing meeting that we pull people together for a roundtable. So basically with CalAIM, I have been inviting CalAIM providers, encouraging them to participate in our case conferencing meetings, inviting folks to bring their cases in, helping CalAIM providers understand how their programs fit into the bigger response homeless response system, and then also helping non-CalAIM providers recognize how CalAIM can benefit their clients as well, and like using case conferencing to point out those places where the two it's not really two systems, it's really just one. It's just CalAIM getting integrated into what we already have. So during case conferencing, we'll have CalAIM providers who will bring up cases, and then non-CalAIM providers will have solutions to the difficult problems that those folks bring into case conferencing. And then in addition, we're and CalAIM ECM providers to have individual case conferencing for really complex cases, to bring treatment teams together for one particular client member who needs special attention to wrap services around them so that they can be successful. So yeah, I'm just kind of encouraging partners to teach each other what they do, because between us all, we can do the work that needs to be done.
That's so true. And having spent the majority of my career working in complex care or underserved populations work, our support of each other is so important in this work. And also our ability to deeply build trust with the clients we serve, and to have integrated ways that we meet their needs, so that things make sense, respect the person's story, and really resolve issues quickly. Is there a client or a story that you could share with us about what that actually looks like in practice?
Sure. Yeah. I mean, there are many situations, but for example, we have our case conferencing roundtable. So we'll have 15 or 20 different agencies represented in the room, and a person from one CalAIM agency will mention a client, and I'll use the name Nathan just as a name, but this agency had been given Nathan's name in a member information file from managed care. So this is a person who qualifies for UCM. Try to get them connected, right? This is managed care telling the provider, but the phone number that was given was not current. This ECM provider was not able to find this person, so they just brought up their name. Like, I don't know if this is going to do any good, but hey, I'm looking for this person, and they mentioned Nathan's name. It was exactly what needed to happen. And that being in that case conferencing setting, a non-CalAIM provider who does street outreach had come across Nathan on the street, and they're like, oh yeah, he's around, because I had heard that Nathan had left town, but no, Nathan was still around. So that non-CalAIM provider was able to link Nathan back to the CalAIM provider, and then Nathan was able to get connected to services. We can't be in every place all at once, but we have partners who are in all the places that we're not. So that was just one of many specific situations where because we have eyes everywhere. When we come together, we can actually wrap services around these folks.
I love that. And that's so true. I forgot to say at the beginning, what's exciting about this role is incentive payment IPP dollars from the health plans are what is funding this role. So it's a partnership between the managed care plans, the community providers, and the community itself. So Eddie, how do you see this playing out in universal practices across the country related to this? We go to the next slide.
Thanks, Lauren. Yeah, we'd like to give you all, no matter where you're currently at with some of these practices, we'd like to help you find a next step to try out. So the first one is mapping assets. We recommend starting with what you've got and not with what you need or with what's missing. If you haven't yet, inventory every single service and connecting tool. That means coordination meetings. That means technology that you use for coordination. If it's an asset, get it on a sheet of paper and share it out. Once it's written down, people can start to look for ways to optimize and make new connections between your assets. If you already have a map, they tend to be outdated. Have you updated it periodically? Have you updated it in a collaborative way so that everyone from their vantage point around your system is saying, wait, we also have this. and adding to it. We have a resource to share. You can find our email there on the screen. Email us. We have a system of care asset map that Lauren and others have developed. We'd love to share it if you'll find that useful for asset mapping. We also have a resource, just a one-sheet guide to making your case conferencing meeting more action-oriented. I encourage you, get past the updates meetings. So many case conferencing meetings are updates meetings. We want those meetings to spur next steps, actions, referrals to community supports and ECM. So if you'd like a couple of tips, email us and we'll send you that case conferencing action-oriented tips. The third piece is train community partners to make referrals. What we find a lot of the time is that provider staff feel like they've got to go it alone and they've got to go reach out to clients and maintain the system on their own. Think about the clients you need to reach. Where are they spending time? Emergency departments, community colleges, faith communities, where encampments, wherever it may be, go to those places and think about how to connect with the folks who are connecting with your potential clients so that you can have everyone keeping eyes on referrals. We'll share one more tool with you on the next slide, which is this tool that Turning Point created. We think it's really great. We can share this deck out too if you email us. This slide in particular shows how ECM integrates with other services from the members' perspective. And so a nice thing about creating a presentation like this is that you can adapt it for whatever audience you're talking to and get them thinking about how to work with ECM. And so with that, I'll hand back to Lauren.
We want to thank Turning Point for sharing this with everyone in the state. They did a lot of work on this, and it's really great to have a resource to start with. So if you go to the next slide, Eddie started talking about case finding and embedding. And if you go to the next slide, this is another universal practice that's super helpful. So embedding means you're building relationships, you're building trusting relationships with the people that are serving the clients that might benefit from CalAIM. So the agencies where people spend the most time, it might be a shelter, it might be a hospital emergency room, it might be a FQHC. You're building relationships there, and you might actually have a scheduled time where you go there every Monday, or you go there a certain amount of hours every day, so that it's very easy for clients to access the CalAIM services. So embedding is one practice. And another is using data to proactively find people who might benefit from CalAIM. So you can use the health management information system or electronic health records in hospitals or primary care. When I was doing this work, I ran a daily report in the hospital, and I knew who was in the building who qualified, and I knew who was in the ER where I could go talk to them right now for who would benefit from services. So Iris, we'd love to hear from you. How is that playing out in Kings and Tulare County with the work you're doing?
So at the client facing level, this is what we do. We meet clients where they are. So we have embedding, we have outreach teams that are, visiting the encampments and getting to know folks where they are, getting to giving people the opportunity, people experiencing homelessness, the opportunity to present their situation from their point of view, instead of coming at them from ours and saying, this is what we have, let me help you. We're going to them and letting them tell us what they need, and then trying to provide services from that angle. And then from the CalAIM coordinator perspective, I have visited about 25 different agencies where they are. I've talked to them in their space to help understand their passion, their mission, why they do what they do. And then that helps me help them reach their goals, which, ultimately is to serve those folks out there experiencing homelessness that really need the help. And that's how embedding has really, it's the connection. It's that space, that place where the connection, the relationship building happens is in the embedding. It's in that meeting you where you are component.
I love that. Let's go to the next slide and tell us about data. How have you been using data, Iris?
So this is a snapshot. I will say that the total, this is a measurement of the number of folks who are enrolled in CalAIM in HMIS. So there are more people than this enrolled in CalAIM, but this is just capturing the ones who are in our HMIS system, in our homeless management information system. So we're actually up to 433 now. That number is a little behind. But so basically what I have been doing with this is, because my background is in housing, I understand HMIS. I understand the data. I've been working with Kings United Way, who is put this dashboard together to try to understand the CalAIM data. And I'm digging into that data to identify folks who might be qualified for ECM and community supports, primarily ECM. So I'm looking at, we use the VI-SPDAT for triage assessment for our programs. So I'm looking at the VI-SPDAT data and then trying to, for instance, an example would be if someone has 30 emergency department visits in the past 6 months, then I am filtering them toward maybe Kuya Health or one of our healthcare providers who are providing ECM. Whereas if someone has had 30 interactions with law enforcement in the past 6 months, I might gear them more toward one of our behavioral health that foundation programs that are providing ECM. So it's just using the data that's available to help curate the referrals in a way that provides the most potential for success, because ultimately we're trying to get that connection made. And so just kind of like looking for ways to direct that connection so that it has the most chance for it to being successful.
I love that. I think the faster we can get people connected, the better. And Eddie, tell us about how is this playing out nationally? What could people do in their own community if we go to the next slide?
Yeah, two quick ideas. One, partner with your continuum of care. ECM and community support should be held very close to what the continuum of care is doing. So think about how you can work together to pull an HMIS report to find potential clients. If you're already using HMIS, start to ask each other questions. How can you speed up referrals? How can you tighten handoffs? Are we getting the right information from HMIS? Do we need to be cleaning up our data entry processes? Make the most of that incredible tool. And similar to your EHR, if you're working with, if you're tightly integrated with hospitals in the county. The second thought we'll share, like our friends at PCG, think about small tests of change. Don't try to boil the ocean. Don't try to find every single shelter and hospital and school and church to talk to tomorrow. Start with one. Think about one site for one day. How might you embed and just see how it goes to use that location to make new referrals. We have one more chunk of content on warm handoffs. Lauren.
So if you go to the next slide, one of the most important things, so we've talked a lot about trust. Trust really matters. If you have a history of trauma or difficulty, trust is a precious, precious thing. Trust between providers is also really important. So one of the best practices nationally to build trust and build integration for the clients we serve is a warm handoff. So if you go to the next slide, really thinking about how do we build integration and clear information and handing out the story really well. Iris, can you talk about how that's playing out? What does warm handoffs look like in practice, and what kind of resources are you using to do that?
So this is a really critical point in the system for whether we're going to have a successful person who's going to be successfully housed. If you're a person experiencing homelessness and you make a good strong connection with an outreach worker, that relationship is giving you momentum to move forward. And so if you're going to move into a new situation, into a housed situation, there's a lot of stress that goes with that. And you need to know that you're not alone. As a person experiencing homelessness, you need to know that you're going to still be connected in a safe and be safe in your transition. As a worker, if you have spent time and energy developing a relationship with that client, you've seen them grow, you see their potential and their momentum, and then now they're going into a next phase of care. You need to know that next phase, that next worker is going to give them the same person-centered and individualized treatment that they've been getting from you. You're transferring your trust to that next person, and then the person experiencing homelessness never feels alone, never feels isolated, and there's less likely to fall through the cracks. They're
It's
gonna
so important.
yes.
So important, and what we all want to feel, right? So Eddie, take us home. I know we're at the end. We could keep talking for a long time, but we want to have a chance for you all to ask questions. If you can go to the next slide.
You know, I'll just maybe ask Iris, is there anything that's essential that we know about this simple handoff tool? Maybe the one thing that I'll say is a word of framing is just like when any of us go to the doctor and we get a lot of information and instructions, it's helpful to have a thing to take away with us so that we have a written document to know what's coming next. I think this handoff tool is some version of that. Iris, anything that we should be thinking about how to make this handoff tool useful?
I mean, this is one of 2 or 3 that are being used in our system right now. It is about making sure that the whole person is all of the needs for the whole person care is what is sticking into my mind, but that we are wrapping services around the whole person. So by going through and making sure that all of these boxes are checked, that we have information in all of these categories, we're making sure that all of the various levels of need that this individual has are being addressed. And so it's really important to just like understand that when you're passing this piece of paper, there's a person behind it with strengths and barriers and needs, and that we're handing that off. We're handing off a piece of paper, but what we're really doing is handing off trust and responsibility.
That's so key. And so that we can share this tool with you. If you go to the next slide, that concludes our presentation. We're happy to reach out and talk more after this, but we want to hand it back to Emma for a question and answer. Thank you so much.
Thank you, Iris, Eddie, and Lauren, and all of our presenters. I hope across these 4 strategies and resources we've talked through today, that everyone in the meeting feels like they can walk away with something to test or try out to help your practice and engagement with CalAIM. We have nearly 700 people in the room today, and I think like nearly 40 questions in the Q&A, which obviously we won't be able to answer all of them, but we'll try to take just a few. And I just want to reassure everyone that we are going to look at all the questions afterwards and post responses to those common relevant questions. So the first question is for BluePath, and it's a little bit about customizing those job aids across counties. Specifically, a question was asked, are the tools MCP specific as well? For the person asking the question has 3 MCPs with different ECM and community sports programs, for example. I can just start with that.
Thanks, Emma, and thanks for that question. So in the cases in the job aid where there are multiple MCPs that are offering different community supports within the same county, we have noted with an asterisk on the community support, this is only available for Kaiser Permanente members, or this is only available for Alameda Alliance for Health members. So that piece of information is included, and you'll see it there in the job aid. And then as far as customizing for different counties, all are welcome to take what we've started here and create a version that is relevant for your specific county and what your community needs.
And then, thank you, Madison. Another question for the BluePath team. Was there discussion on how to incorporate the ECM provider value proposition, like what selects nonprofit as your ECM provider on the tool? The person who asked the question noted that ECM providers do not have budget to create marketing materials to create awareness for their programs. So just curious how that might have factored into the development.
Sure. Yeah, I can take this one. Thanks, Emma. While As a facilitator organization, we wanted to create tools that are accessible and useful for every organization in the collaborative. So we didn't ourselves put any specific provider name, branding, information like that on this tool. We did actually receive a request from an ECM provider to receive an editable version that they could put their logo on and just put a phone number so that their staff would have that easily available. You can send us an email if that's something that you're interested in. One piece I will just clarify is that this is not intended to be marketing materials, right? This is not designed to be mailed out to every Medi-Cal member in the state or any sort of wide marketing outreach. It's really for provider organizations to use with their teams and partners.
Thank you, Stephanie. Looks like we're getting pretty close to the end, so I might jump ahead to a question from our HC2 IHI team. All right, one question around case conferencing. How do you manage confidentiality during these case conferences? Are you securing an ROI from the client or doing anything else to kind of overcome that barrier?
So yes, when we're meeting in case conferencing, we have a case conferencing confidentiality agreement that we partners sign together, and then when clients are we have ROIs that are system wide. When clients do our intakes, like they're acknowledging we'll be discussing their cases with other housing providers. Like it's a part of confidentiality and consent are part of our conversations with clients from the very beginning. So we just, we're very careful to make sure that we understand that we are working with clients' personal information.
Thanks, Iris. And just another question about kind of, how to actually operationalize these case conferences. In your experience, are community health workers able to lead and facilitate a case conference meeting, or do you see that maybe a licensed individual, like a licensed clinical social worker, should be leading the meetings? Any guidance there?
So the person for individual case conferencing for complex cases, the person who knows the client the best should lead that meeting. It could be a licensed person or it could be a community health worker. It's the person who knows that client the best, who knows their needs and what the client's perspective the best, at least in my opinion.
And it can help also to have a universal standard framework for how you do report out or how you have the discussion about what's happening for the client. Both Eddie and I have built toolkits and worked in other communities, and I've seen faith leaders lead case conferencing. I've seen police who are involved in the population lead case conferencing, and also doctors and nurses and social workers. The core principles are really important, that you respect the person and their story, that you respect each other in agencies, and that you're assuming good intentions, but also that you have a structure around what you talk about that often makes it much more effective. I don't know, do you want to add anything to that, Eddie?
The only piece I would add to that, I agree with all that, is find someone who's good at facilitating. Find someone who's got facilitation skills and is willing to get feedback about their facilitation skills, because there is, it's an art, not a science, to get the best out of folks in a room. So find someone who's good at that. I think that may be more important than their certification.
Thanks, everyone. All right, just in wrap up, I'm going to ask if Sean or Grace Ann could go ahead and launch the evaluation poll and go to the next slide, please. I did want to just note the email to reach out to HC2 Strategies for the resources that they went to is just a moment ago posted in the chat. So take a look at that, as well as we've reposted the links to the BluePath county-specific job aids. And I'm going to turn it over to Rebecca to close us out for the day.
Thank you, Emma, and what a wonderful webinar that we have had. Thank you so much to BluePath and HC2 for joining us and reviewing all of those great tools for all of you as you implement ECM and community supports. We do have 26 collaboratives. If you have not yet registered to participate in a collaborative, we encourage you to do so. And we're going to drop the link in the chat now for you to easy access and register for one of the collaboratives. Upcoming in late fall, early winter, end of year, we are going to host another best practices webinar. So please do keep an eye on your news feeds, as we will be announcing the next best practices webinar, as well as topics in the next coming months. And then finally, as Emma said, we have launched a poll. Your participation today and your attendance today is greatly appreciated, as well as your feedback on today's webinar. So we do ask before you exit the webinar today to take just a brief minute to answer the evaluation poll that has been launched in the chat, and of course the questions you see here on the slide. Your feedback is very valuable to us. So thank you in advance for completing that poll. And thank you for attending our webinar today. We appreciate your attendance and we hope you have an amazing rest of your day. Thank you so much.